Okay, very excited for our next speaker. As you can see, he's meeting all his adoring fans as he's walking up. No, it's okay. I'm doing your intro. You're fine. This is Dr. Eric Montminy. He was one of our beloved fellows, and we are so excited to have him back this year. He's going to be talking about pancreatic pseudocysts, which is a big interest of mine. I hope you guys enjoy it.
Awesome.
Yeah.
Oh my God, I know.
Oh, here's your clicker.
Oh, nice clicker. Hi, everybody. I'm Eric. I was a former fellow here, and I think this course is amazing for all of you. I hope you guys all take it in throughout the weekend and just enjoy this, because I remember when I first came to this course, I was just blown away by the expertise at every single level. I think on the nursing end, you guys are the engines, the workhorses of all these cases, and just seeing how much you can learn from seeing so much complex endoscopy happening. But I'm here to talk about pseudocysts, so we're kind of shifting gears from a nice, beautiful resection. And I love this graphic that was just automatically generated, because this is really, as we go through this, really what's going on. They couldn't have picked a better AI. Couldn't have picked this beautiful network of surrounding assists. So I have no disclosures. I've got some objectives for CME, but so let's just talk a little bit about the pancreas. Okay, so there's pancreatic anatomy. It's seated mostly behind the stomach, and that's about 2/3 of the gland. And it's broken down into a head, uncinate, neck, body, tail. But when you're in the stomach, you're primarily seeing or around the neck, body, and tail portion. But it does have a little component of it nestled or cuddling up in the sweep of the duodenum. And so, are you able to see my pointers, or do I need to do the? Oh, okay. All right. But in this end, this is the duodenal sweep. And this is where you're going to find the other third of the pancreas, that being the head and the uncinate process. It contains a ductal system, very similar to like the branches of a tree, okay, or the lung that we think of. But it has a main duct that branches into littler ducts, and those littler ducts branch into even smaller ducts, and that kind of network comprises of this main duct, but within these things called side branches. So when you hear a side branch, it's these little itty bitty branches off the main duct, okay? And that's really important with what we're going to be talking about. A little bit more into the anatomy, just bringing it down to like a little bit more granular level, because it's really important. There is two components of the pancreas. There's the endocrine function and there's the exocrine. And that's just fancy doctor talk about hormone functions and digestion functions of the pancreas. So endocrine, we think of insulin, we think of, glucagon and all the stuff that we think about with diabetes. That is the one hat of the pancreas. When we're talking about pseudocysts and all the pancreatitis injuries, we're thinking about the exocrine, or the stuff that the pancreas does to help with digestion. So there's two types of cells of the pancreas that are really important in the exocrine function. That's the acinar cells and the intercalated duct cells, okay? These are within those little side branches, and the very distalist most, or the very granular furthest away from that main duct. Acinar cells secrete enzymes that we use to digest. So those are things like lipase, elastase, proteases. Intercalated duct cells, they actually secrete bicarbonate to help with the pH of how we digest things within the duodenum. It also helps protect the duodenum from getting too much acid exposure. So bicarbonate is a base, okay? It's the opposite of what we think about in the stomach being the hydrochloric acid, right? And we think acid, burn, chemical burn. So this is like our little buffer in the small bowel that helps us from getting a really scary chemical burn. So those very, further away from the main duct cells, they secrete into something called an intralobular duct. Okay, so these are the tiniest of the ducts of the side branch. Those drain into interlobular ducts. So those are just bigger collecting ducts. And those together will come together from multiple parts of the pancreas to secrete into the main pancreatic duct. Okay. So when you're thinking about a side branch, it's anything of along the way of these two. Okay. These are going to be most often what you see. These are really flimsy parts. You really are not hoping for a main duct injury that leads to a pseudocyst. Okay. So this is very important for us just to kind of conceptualize, because this is the source of where we're getting our pancreatic fluid collections that lead to pseudocysts. Okay. So when we think about pancreatitis, you really need to equate that to injury to these cells. Okay, so we're talking about just inflammation to the pancreas. So acinar cell injury, and you can get that by multiple pathways. So interstitial edema, or the surrounding infrastructure of the pancreas, can get edematous from, like, say, a stone or any type of stricturing obstruction. So you're just getting a lot of fluid that's gathering around. That leads to ischemia, because there's little itty bitty blood vessels that supply this. Swelling will compress those blood vessels, leading to poor blood flow, leads to inflammation. Okay, it's very similar to what happens when you get a gallstone in your gallbladder. Okay, gallstone is, you get a gallstone obstructs your main cystic duct, your gallbladder gets really distended, and then all of a sudden the blood vessels within the walls of the gallbladder get compressed, and that's what leads to cholecystitis. Okay, very similar to pancreatitis in this pathway. You can get toxicity. I think many things can cause inflammation that we ingest. I think we often associate it with alcohol. I put a little asterisk because alcohol is not definitively shown to be directly causal to cause pancreatitis. It's been strongly associated with chronic pancreatitis, but if you see people who binge alcohol over and over again, many of them do not get pancreatitis. What they think that is actually with alcohol, it has to do more with often predisposition on this other side being defective cells. So a lot of times people who get alcoholic pancreatitis, they have some underlying genetic predisposition that basically their threshold to get pancreatitis is lower. So we talk about genetic hereditary pancreatitis conditions, things like, you'll hear like PRSS1s and SPINKs and all these different alphabet soups of genes that people get labeled with that you see in their charts with all the fancy doctors speak, but those patients tend to be the ones that have either a carrier for one of those that are actually more common than we think, that have that predisposition for alcohol. But either way, you're getting some type of collection towards an acinar cell injury. And what happens in that case is acinar cells will have these activated enzymes that will then be exposed to the gland. You're literally getting a chemical burn to your pancreas or the surrounding tissue. And why is that scary? It's because you have a lot of fat in that area, you have a lot of protein, and the pancreas is supposed to be breaking that down. What the scariest thing that comes out of the pancreas that I worry the most about is that the pancreas has an enzyme called elastase. Okay, what makes up elastin, which is the integral part of that area, are very strong blood vessels, so arteries and veins. So you can get hemorrhaging in that area. Okay. So we talk about just kind of redirecting this towards the pseudocyst progression, and what really is going on, I think, the macro level is we get some type of acinar cell and ductal injury. So on CT scan, this is a beautiful kind of progression within this patient. You see like kind of really puffiness and what we term fat stranding. So these little wisps around the pancreas, and unless you're literally looking at these every day, you sometimes don't appreciate it, but the pancreas should be pretty well defined, kind of like how this liver is, right? Or the stomach. Right there. So it's just very puffy, and that's just edema causing a little artifact within that area, so you don't see it real well. And that over about a week, you'll see this puffiness start settling around the pancreas. And so this dark part, these are what's termed an acute peripancreatic fluid collection. Okay, so bear with me. Okay, so we're getting into the alphabet soup. So APFCs. And then over about 2 to 4 weeks, this is going to collect, and your body's going to do a beautiful thing that it does and start building a barrier around it to try to heal this and inform something called a pseudocyst. Okay. So progression from initial injury to a nice, safe, walled off collection, about anywhere from about 2 to 4 weeks is usually what we see, more on the 4-week end. So why we keep calling this a pseudocyst? What is that? Why did we even come up with this term? So you can thank a pathologist for this, okay? So pathologists like to, be very, fundamental and strict with their definitions, okay? So medically speaking, a cyst needs to have something called an epithelium layer. So within the capsule, meaning there needs to be a special type of cell lining within this structure for it to be specifically called a cyst. Pseudocysts, when they form, take that inflammation tissue around it and kind of encase that. That is not a cyst, quote unquote, per se formation. It's just hardened inflammatory tissue, what we term granulation tissue. So this just hardened goop that's forming to help encase this from no longer being free fluid that glues together. So that's why we call it a pseudocyst. We don't have these histologic layers that we see in a true cyst. So what do I try to tell patients what this is? Because patients be like, you telling me I have a cyst, but you're saying it's a pseudo? I thought this is this like some type of pseudoscience? What's going on here? And I really just kind of liken it to something that's common. So I tell them they have a blister on their pancreas, and they get it then. They're like, oh, okay, so you have this like big puffy thing that formed after a burn, and they just get it. So I tell them that you just got this big bubbly blister on your pancreas, and sometimes it needs to be popped, and that's what we're going to talk about next, okay? So, but we're going to first just, again, kind of on the granular layer, I want to tell you what really is happening, okay? So what really is important for us to summarize before we start going into intervention is you must have an injury to somewhere along that ductal system, okay? And either in the main duct, which you hope is not the case, but equally the side branch can be an annoyance, but tends to be a little bit less severe. But you need some injury. And what would cause that? It could be pancreatitis, so activation of those enzymes that I talked about. You could have trauma, so someone getting in a car accident or a penetrating injury. I work on the south side of Chicago. We see a lot of gun violence, unfortunately. I see tons of pancreatic pseudocysts from bullet holes going into patients. So surgery is also one of those things that you will see pseudocysts form. Why is that? Because they're intentionally causing trauma. They may inadvertently cause an injury to a duct that they may not have meant to, or you have blood vessel supplies that may not be healing. You may get a focal area of ischemia. Those acinar cells may get inflamed, cause pancreatitis, yada, yada, yada. You get a ductal injury, and now you got a fluid collection and so forth. When I mentioned that timeline, right, of it taking about from about 2 to 4 weeks to happen, why is that like so universal? And within your body, you have an inflammatory reaction. I know probably some of you remember all the way back to physiology class, and they talked about like fibrosis and how you got stellate cells to be activated, and you talked about all these alphabet soup enzymes that got activated, and you instantly forgot it, like the Krebs cycle, right? But why that actually happens and why it takes about 2 to 4 weeks of continued activation of that inflammatory process to start forming this or activating the cells that make fibrosis around fluid collection. So that's why that happens, and that's why that is the scale it takes for about 2 to 4 weeks. What's really important is that most often these are sterile fluid collections as well. The abdomen around the pancreas should be as sterile, hopefully, as the OR that you're in, okay? There is instances where you can get contamination and infection of pseudocysts. Those are scary, okay? Why that may happen, you could get bacterial translocation, so inflammation, and your gut is filthy, right? You have this billions of germs, and inflammation may loosen up that barrier that you have and get into that peripancreatic fluid collection before it walls off, and now you've sealed that peripancreatic fluid collection with inflammation, and now you have a perfect broth for bacteria to germinate, right? Other things like you could have had, unfortunately, like a surgical contamination. Most scariest thing, in my opinion, is like you've had a lot of inflammation in the area, and you've got now a fistula or an aberrant connection between the duct, or the cyst, and something that's contaminated, being like the bowel. How do they present? Again, you have to remember, when was their pancreatitis, abdominal trauma, or surgery? So that's in the back of our mind at all times. Because again, it's important that if they're not hearing about that and you see a cyst, it could not be a pseudocyst. Okay, this could be an IPMN that we hear about, or another mucinous cyst. So if you're not getting that piece of history when they present, you need to start thinking about other things. And it's also, again, like we talked about, important for timing of intervention on these. Classic symptoms for pseudocysts, you may get abdominal distension and bloating, right? This is right by the stomach and the small bowel. You're getting food put in. You have something that's like expanding like a balloon, right? And it's starting to press on that. So you may get fullness, early satiety. So you eat a couple bites, ugh, I don't want it anymore. Abdominal pain because you have a lot of nerves, so your enteric nervous system in that area. Nausea, of course. But often you don't feel anything, okay? Your abdominal cavity has a lot of space, correct? You have a lot of room for this to start getting bigger and bigger before you start feeling those compressive symptoms. Again, worrisome things would be if it was infected, and that's actually less common, right? This is supposed to be sterile. But if you're seeing things like fevers, hypotension, decreased urine output, or respiratory distress, you're really concerned. That can be pretty worrisome, that you need to have some type of urgent intervention. Nurses, I love, because you guys are so good at knowing all the instruments that you've learned throughout training, whether it be for Foley's or or bladder pressures, all that stuff. And so, like, I feel like you all know when these are turning south faster than a lot of doctors do. So, like, why would a decreased urine output happen? Well, you could have a big expanding pseudocyst that's taking up the full cavity. You all know about intra-abdominal pressures really well. You may pick up on that a little bit faster than doctors will, but that would happen because the IVC, this main vessel that's traversing the abdominal cavity, is starting to get compressed on. You're getting less cardiac return or cardiac output, and venous returns going down. So a little bit more urgent situation that you need to pop this pimple or this blister faster. So when we're talking about treatment, you have to first bring it down pretty basic. So are they symptomatic or are they not? So a third of all pseudocysts don't need intervention. And just that, as far as data looking, you won't intervene on any of them, because about a third of them are going to be asymptomatic and you can just watch them. Okay, but of the 2/3 that do need to be intervened on, those are the ones that are going to be the symptomatic ones. So presenting with those symptoms that I had discussed. You have 3 little buckets or silos that you should be looking towards. So you have endoscopic management, which I like to think of as, we're in an endoscopy course, obviously, is the best option. You have percutaneous options, and really, in my opinion, should be reserved when endoscopy is not available. And then your last resort now is surgery. Okay, you have just all the morbidity that comes with surgery. We try to avoid these two because it's not just like the procedure, it's all the mess that can come after. It's all the collateral damage, the baggage that comes with doing these. Of percutaneous options, the biggest one I worry the most about is, yes, it can drain a pseudocyst really nicely, but that is pancreatic enzymes. Those enzymes are meant to cause inflammation, or basically chew up everything that you see. And you're putting a connection between the skin and the pancreatic fluid that's within that cyst. And we see high rates of pancreatico-cutaneous fistulas. You want a hard fistula to resolve. A pancreatic cutaneous fistula can linger for years, and it can make people miserable. We have something that's meant to chew up and make things dissolve, being pancreatic fluid. Imagine pouring that on your skin over and over and over again throughout the day. Patients can be very miserable. So we try to avoid those. Sometimes they're necessary because you have a collection that's been away from the reach of the endoscope, and you need to bite the bullet and try to get that out as soon as possible. Of endoscopic management, you have really 2 big buckets. You have transmural, which I like to think is EUS based, and transpapillary, which was ERCP. Transpapillary really came first. and they each have their benefits. But since the advent of EUS and interventional EUS, meaning like things that we do during EUS, not just looking, we have had such great success in improving these outcomes. So I'm just going to kind of go for the rest of the time looking at the different modalities we do within endoscopy. So I think within transmural, so we're in the EUS bucket, we have cyst gastrostomy. So cyst being the pseudocyst, gastro being from the stomach, usually ostomy, meaning we're creating a hole or a connection, okay? And we use primarily right now, I think for the most part, lumen-opposing metal stents. You'll see this, the trade name, you see them from Boston Scientific, Axio stents. You have other ones in different countries, but primarily this is the major share of the market when we talk about LAMs or Axio stents. What it really involves from the procedural side, and it's an intentional perforation, okay? You're burning a hole into the stomach or the small bowel, wherever the pseudocyst is easily accessible, and you're entering the pseudocyst under like what's that yellow pedal, or what we trying to term pure cutting current. Now, a lot of your electrocautery units, whether you're using IRBI or whatever, these are your, mostly, cutting features and lot less of the coag. So you're not going to be hitting blue pedal. So you're going to be hitting yellow pedal to just really fast get through and through, because you want to immediately seal that perforation with the stent deploying. This is a bougie catheter that the tip is kind of conical at the end, so it's not meant to make a big hole. It's meant to make basically a sealing hole as it goes across. Excuse me, I hit the mic. And then what you'll do is you'll deploy both ends of the flange of the stent, and it will just immediately drain that into the stomach or small bowel. I think it's really important because sometimes these can be really big, that you have these patients in a good position so that they don't aspirate. Very rarely for pseudocysts, I will ever not intubate these patients. There would have to be a significant, issue with intubation. They have a lot of issues with fistulas and, or, esophageal bronchial fistulas or something that would be putting them at risk for an issue. And if that's the case, I have to be very gentle when I'm doing this procedure. What's the benefit of this the most? It minimizes leakages around when you puncture, and it's a large caliber stent so patients get immediate relief almost. So here's a video I have. I hope this works. Isn't that what everyone says, like during every presentation? I hope this video works. Oh. Okay, so here's courtesy of my partner. So you saw that burn, that kind of flash bubbling over here. Here. And that was the catheter burning through the stomach, okay? And now you're going to start seeing the flanges be deployed. And there's what's known as the proximal flange on the endoscopy side being deployed. And now we're going to be pushing out the catheter. And this lumen-opposed stent metal stent looks exactly the same on the other side. So now that little hole in the middle of that stent is where the fluid, now you can see it nice start trickling out. You try to use usually the largest stent you can get in, but you want to make sure that, you're not putting too big of a stent in. So these come in 6, 8, 10, 15, and 20. Usually I'm reaching for 15s and 20s for this because I want immediate drainage, good drainage, but I want to make sure I'm in the right position. I'm not going to obstruct the pylorus. So the patient now goes from having an obstruction from a pseudocyst, now they have a gastric outlet obstruction from my big flange right here, okay? So it's kind of an art as opposed to a science of which is the best, I would say, but most of them are going to be 15s and 20s, okay? Okay, so double pigtail stenting. This is the old school way, okay? This is before lumen-opposing metal stents were introduced. Works really well still, okay? It's less likely, like I said, to be performed when now it lands here, but it's still performed. Like I did one of these about 2 weeks ago. The most often reason why we will do a double pigtail cyst gastrostomy is because that lumen-opposing metal stent needs a certain amount of distance or less between the bowel and the pseudocysts. Otherwise, we can misdeploy the stent. So if you have a little bit more length between the wall of where you are and the cyst, you may be reaching for this just because this gives you a little bit extra length. Because if you see on, well, I'll show you in a second, these you have the main portion of the stent, and then you have the little holes on the ends where the pigtails are. So what this includes, you'll puncture the pseudocyst, usually with a 19 gauge FNA needle, whatever your dealer's choice of what that is. You'll place usually 2 guide wires side by side. Nice little trick now is, you take a cytology brush over one of those guide wires with the cyto brush removed, and now you have another hole access, so you can put both wires in when you actually only punctured once, instead of trying to puncture once, put a wire, and then have to reposition, puncture again, and get a second wire in. It could be a little bit cumbersome. Depending on the how firm and dense the inflammation is, and how big the wall of the pseudocyst is in your stomach, and what the kind of clinical presentation is, you may have to use some cautery still to get your double pigtail stents enough room to get into the pseudocyst. So using a cystotome is often used now. Some of the devices that we've used for like biliary dilation, so your balloon dilators, have gotten a little bit firmer, and you can give a little bit of back tension on the wire to kind of get it across to even create that room. And then what you'll do is just deploy the double pigtail stents one at a time over each guide wire, usually under fluoro. Again, the downside of this is you're using a smaller caliber stent. So these are usually 7 or 10 French stents. Usually on the 7 French, it's just hard to push a 10 French double pigtail through things, especially when you're using an EOS elevator as opposed to like an ERCP elevator. So you may not get as immediate drainage and symptom relief as you'd like, and sometimes they can clog. The other big thing is every time we do those exchanges, you're pulling something in, a catheter in and out of something that has just been popped, right? So you can get leakage of this fluid around a sterile space. So you can possibly, if it was infected fluid, or it's got some bacteria in it from translocation, you now have contaminated the peritoneum. Now you have peritonitis. But also just fluid in the abdomen is painful, okay? You think about bioleaks. Bioleaks can cause something called bilious peritonitis. It's not pleasant for patients. Our goal is not to do a pseudocyst and then give someone peritonitis for pain. So you want to minimize how many exchanges you're doing, and this is the one thing that can be a little bit of a downside. Here's a nice little example. I don't have the video of it because it's so old, but you can see the 19 gauge needle up here in the pseudocyst, and then they would coil wires in here and then advance the double pigtail stents. And you can see those are the holes that on top of the actual patency of the stent itself, but those little holes will help with drainage. There is transpapillary drainage. It is, I would say, the least often performed, but I still do it often if I get the opportunity, or I'm provided the opportunity, because it does work really well. The most often we will do this is if someone has some type of symptom, but the pseudocyst is just too small to fit some of these other stents, okay? So those Axio stents or luminopolsin stents, they need a certain amount of space to deploy those stents safely, okay? Especially if you want to use bigger ones, you're needing like at least a 3 or 4 centimeter cyst, usually a little bit more to make you feel a little bit more comfortable. Transpapillary drainage doesn't rely on that, okay? You have, like, say, for instance, someone with jaundice, and they have a pseudocyst forming right where the bile duct and the pancreatic duct are meeting, and it's compressing your bile duct. And so we need to get this decompressed somehow, but it's too big or too small for us to fit our EUS guided approaches. And so this would be a perfect example of when you would do it. What happens with this? It's just basically doing an ERCP. You're getting the wire to go into the pseudocyst or around the pseudocyst, and you're placing a stent. Excuse me. So what you'll do is you'll place your pancreatic duct stent. You'll inject some contrast to help localize where the pseudocyst is really taking off. So seeing where the injury is. Often your endoscopist will do a sphincterotomy in the pancreatic duct. So we think about biliary sphincterotomy. This is one of the indications for pancreatic orifice sphincterotomy. You do that because you want to place a stent that's at least 7 French or 10 French, and you just need more room to make that. So that's why that cut is made. Also, will collapse the pressure within the pancreatic duct to help with collapsing the stent. Okay. Why this kind of has fallen out of favor is because we worry about causing more injury, right? When you're cutting, you can cause bleeds like like a post-ERCP bleed. You can worsen pancreatitis. It's not as common, but it still can happen. And it's more from the initial cannulation. A lot of times they're not getting pancreatitis from the contrast that you inject because it's just spilling out into the pseudocysts usually. But sometimes these cause strictures in the area and you can get a retainment of contrast. That's where one of the ways you would get contrast-associated pancreatitis. But usually the pancreatitis can occur from that initial cannulation. You're futzing around and then you cut and you cause a burn to the area and that cautery inflames the pancreas. So you could, cause even more pain. But you can help minimize some of this stuff, again, with some IV fluids and indomethacin, and then really trying to get that stent in place. Here's an example that I did, okay? This was about a month ago. So I was doing an ERCP. This patient was jaundice, had pancreatitis, had a pseudocyst. I was just planning to just place a stent because I was planning to, he wasn't super sick otherwise. He was fine. It was really reliable. It was going to come back as an outpatient the next week when I had enough time to place an Axios in. And you can see on this first picture, I already have the biliary stent, but my first wire I got in was this big guy that was just looping up here, and I knew exactly that was in the pseudocyst. So I got inadvertent advantageous. It was like one of those things where you're like, yeah, I meant to do that, it was that was it. That was the plan all along. But I basically got the wire went into the pancreatic duct, but then automatically went into the pseudocyst, just coiling all the way up there. And this was spilling out on my sphincter tome. So you do enough of pseudocyst drainage, you kind of pick up on how they look when the fluid looks. And I knew right away that was like pancreatic pseudocyst juice. So I placed a biliary stent, did a sphincterotomy, and you can see, I don't know if I can see it over here. Right here, I don't know. You can see my double pigtail that I put into pseudocyst. So that's a classic transpapillary drainage. Patient came back 4 weeks later, upsized the stent once. 4 weeks after that, pseudocyst was gone. So, like I said, these can become infected, but you're going to hear a little bit of jargon in between pseudocysts, walled-off necrosis. They seem kind of like the same thing. They're actually not. Okay, so pseudocysts walled-off necrosis is you've gotten a really bad pancreatitis, so much so that the pancreas is starting to necrose. And that it's starting to liquefy and turn into goop and everything. Yes, you may get ductal injuries. You may get all sorts of stuff that, gets encased. Pancreatic fluid, pancreatic, parenchyma, all that stuff may get kind of brought into that soup pot. But it is not technically a pseudocyst, okay? But it does form that same wall that you see with pseudocysts. It's this inflammatory encasing. So the thing with pseudocysts that look like walled-off necrosis is that when they become infected, you'll see very similar debris and pus coming out. So it's kind of a misnomer that a lot of people will just be, oh, he's got a walled-off necrosis. Well, it's actually maybe just be a pseudocyst that got some pus in it. So they are different things. So like I said, infected pseudocysts do require a little bit more. This is like urgent stuff. We're not waiting sometimes that full 4 weeks. There's been a couple trials that were published in the New England Journal of Medicine about last year, 2 years ago now, that showed that you can actually don't have to wait that 4 weeks. You can actually go up to 2 weeks and be ready to drain these. These are those patients that you're trying to stabilize for as long as you can. Sometimes if they hit that 2-week mark, you're good to go. So prognosis. We're kind of wrapping up towards the end, but prognosis is excellent of pseudocysts, okay? We have about 90% resolution when you have an intervention. Remember though, of those 90%, all that stuff, a third of them weren't even included in those studies because a third of them will resolve on their own. So that's great. The best thing to do, the best pseudocyst therapy is not having to do anything, right? You don't have to put the risk of pancreatitis with futzing around by the papilla. You don't have to worry about perforation complications, leaks, all that stuff with all these stents. So sometimes you don't have to do anything. So this is very good prognosis. And that's something you can tell your patients. What is Some of the stuff that leads to better prognosis is if you identify these pseudocysts before any end organ injury. So your AKIs, your respiratory distress, abdominal compartment syndrome, any type of evidence of like a heart attack or, an NSTEMI happening, a type 2 NSTEMI. These are all things, if you pick up on the pseudocysts before that and start the treatment like kind of pathway, they tend to have better outcomes. Better prognosis on top of that would be people with obviously no symptoms. That's always the greatest. And size is less than 4, as long as they aren't impinging on the bile duct, okay? I always stress that because cholangitis is one of the most lethal infections of the body. So less than 4 centimeters, you're not going to get as compression around this tight space where the pancreas is. But overall, pseudocysts less than 4 centimeters, if you look at the entirety of the gland, tend to have better prognosis. Worst prognosis is they follow these patients a little bit over about 30 days and then 90 days. If they continue to have alcohol abuse after their pancreatitis episode, I think that has to do more with the disease of alcoholism more than anything. Alcoholism tends to affect the prefrontal cortex. So you have people who tend to replace nutrition with alcohol. So these patients who are recovering from pancreatitis and pseudocysts and all this hospitalization, they don't eat as well, they don't hydrate as well. So they tend to have poorer healing abilities. So that's why their worst prognosis is with that. Severe pancreatitis, again, that kind of dovetails back from the detection before any end organ injury. End organ injury is basically a definition of severe pancreatitis. Asymptomatic pseudocysts, there's, like I said, just very little role for continued imaging in these patients unless symptoms start to arise. I like to have them follow up with me in clinic just once, about a month later, just to check in. I like seeing at that 30-day mark that we see for measuring, patient outcomes. Just seeing them in 1 month, hey, it could be, a quick visit. Hey, I saw you in the hospital. I didn't do anything, but I just want to see how your pancreas is feeling. Are you getting any new symptoms? Anything? But given the injury to the patients, I think it's worth your time just to make sure that they understand that this isn't just an in-hospital thing. It may require a little bit of follow-up after. Some conclusions: pseudocysts require not only pancreatitis, but also an injury to the duct. So that, again, I can't stress that enough because there's so many times your team's going to get it referred for a cyst and it looks like a pseudocyst, but it's actually a giant atypical IPMN. You do not want to throw a stent into an IPMN, okay? That is going to lead to poor outcomes, okay? So you need to have that piece of your history. So if your physician has not heard about that, maybe you ask the patient, hey, how was your surgery? Was it hard? Did they have to go in? And you go, hey, doc, I think this might be actually from a ductal injury from their surgery. This is where the only time I really saw in the chart review about them having a ductal injury. The inflammatory process takes weeks to solidify, but that's because we want to make sure the intervention is safe if we have to. And because of that, sometimes it's just asymptomatic. You don't need to do anything. It's happening a third of the time. But I think in the back of the mind, we've gotten to this stage in endoscopy that you all are in now. We have so many interventions. However, each one of these is very effective, and it's about finding the right patient, okay? Those are my references, and thank you. I don't know what my time was like. Sorry. Did I go over?
Never change.
I know. Thank you.
Does anybody have any questions for Dr. Montminy?
For most of these cases of pancreatitis, are you giving indomethacin or is it kind of patient related?
It depends on what you're doing. So transpapillary drainage, I do. If I'm doing transmural drainage, so if I'm doing an ERCP to put a stent, a pancreatic duct stent, into to drain the pseudocyst, yes, I will give indomethacin. My group gives actually indomethacin to every person who's getting an ERCP, whether or not it's your initial or follow-up ERCP. The cost is the issue on that. So that's a trade-off. But we did see a lower risk of complications with recurrent post-ERCP pancreatitis. So in these patients who've already been cut. Okay. So yes, if I'm doing ERCP, yes. EUS, no, because you're away from the pancreatic orifice. You do not see, we don't benefit medicine. Oh, that. This is inflammation will start going through the scarring process itself. And those fistulas will start to clamp down and it'll close up like an ear piercing. So it's really cool. A lot of times this has to do with, if you remember back to like physics classes and everything, with your hydrostatic forces and your oncologic forces where you have like high pressure to low pressure, right? What happens is when you burst a pseudocyst with a stent, you are creating a big drop in the hydrostatic forces. That's why the fluid is flowing out in the stomach. And what you get essentially a collapsing environment that these pseudocysts start collapsing in on themselves, including the fistula itself. So there is a physics component to this, that the pressure itself is even collapsing on the fistula itself. I can count on one hand the amount of times I've had to close a fistula. It's actually been more with people who have undergone different like transmural, like Axios or interventional EOS procedures, but I've never had to do one for a fistula. So, but to answer your question, yes, they often will just collapse on their own. What's really neat about these, especially with pseudocysts, sometimes they can cause enough irritation that they auto fistulize. So you go into do a procedure and you already see a fistula formed. They've caused that transmural drainage by itself. I've seen that sometimes a little bit where it's a little bit more crowded. So if you have a pseudocyst forming in the head and the pseudocyst is just super inflamed and it's running up against a very thin-walled part of your bowels, being your duodenum, it doesn't take much for continued inflammation for the walls to start separating and fusing together, and you've just had a stent essentially placed, but the body did it on its own. For those patients, what I like to do is just place a double pigtail stent to make sure that it fully collapses, but I don't need to put one of these huge stents in. Yes.
I think I used to work at Joe, the doctor that I worked with, would always bring patients back in like once a week to do next time.
Mm-hmm. Yeah. Sure. So that's where I think what you're referring to is where that confusion between pseudocyst and walled-off necrosis is. Pseudocyst usually is a sterile fluid collection that when you drain it, that's all that's usually in there. It's just pancreatic juice and inflammatory juice. That's it. What I think your physician was referring to is having to do necrosectomy. That's where you get necrotic pancreas that just goops up, and you have to literally debride out that tissue. That's where you bring in, them back every week, or if they're admitted, sometimes twice a week. And then the surveillance on for CT scans, I will do one after I've removed the stent, and it's more to see if I'm seeing any evidence of recurrence. Remember, these are 90-ish% effective. There's still going to be about 1 in 10 that are going to recur. Okay, despite all these advances. So I do usually do one. If it's still not grown back, usually after one, and the chances of it coming back are pretty low. I try to minimize how often I'm irradiating patients. I don't want them glowing in the dark. So if they're asymptomatic, I don't continue. And I've seen progress, and I've seen on endoscopy that when I remove the stent, for instance, if I've done a transluminal or transmural drainage, so those Axios stents, if I've seen that cyst cavity just collapse onto the wall of the cyst and I've removed it, I'll do one. And they're asymptomatic. I'll do one CT, and then that'll be about it. I'll continue to follow them in clinic. I think there's no harm in seeing patients, right? You know, you have them check in 6 months from now. It's okay to discharge them a year later from your clinic. They don't, and I think patients, they go through hell with these episodes. These are terrible presentations. Patients are scared. They often are jaundice, or they often had essentially a bomb blow up in their abdomen, and they're in horrible pain. They don't ever want to have that. They can end up getting a lot of anxiety and poor quality of life. There's actual data on the quality of life in people with, really severe pancreatitis. So it's good as you, as the physician or the nurse practitioner or whatever, who follows these patients, to just check in on them and just reassure them that, hey, your symptoms are not there. We don't need to do imaging. I know you're worried about it, but it's reassuring to me. If I feel good about this, I'm really happy. You should be good. You should be feeling better about it. Okay. Other questions?
Just one more. Just because we have a mixed group here, you had briefly mentioned, and you can give a brief answer as well, IPMNs and us not wanting to stent those. Could you just talk a little bit about what an IPMN is
Sure.
and why we wouldn't want to shove something in there?
So what you'll learn is we get referred for cysts of the pancreas, and there are different cysts that occur. One of the most common cysts that we see is something called an IPMN, or intraductal mucus papillary neoplasm. So that's why we call it an IPMN. These are essentially like the polyps of the pancreas, but they're in cyst form. Okay. They do all have a degree of malignant potential. Most will do nothing, but they are not a pseudocyst in that pseudocysts have zero malignant potential, right? Mostly IPMNs, because you don't want to put a stent in those. So it's because eventually they may need to have some type of procedure on them. And putting a stent in them could be catastrophic. For one, they could potentially, if they have any type of dysplasia, they may not act well and start not healing well with a stent in them. So you could get a huge leak. You could cause not only pancreatitis, but peritonitis from doing something like that, because you'll have continued pouring out of leakage of pancreatic fluid from them. The other thing is, it may make it very difficult for a surgeon to remove them. Okay. We're creating fistulas, which creates inflammation, which creates adhesions and all that stuff. And if you have someone who has a malignant or a pre-malignant cyst, like an IPMN that's become aggressive, you really want that to have a definitive management, right? You want that out and have a good margin. And if we're hindering surgeons from having a good margin, we're not doing the job we should be doing. Okay. So sometimes what we'll do, if we can't tell and you're not getting a good history, is, even though it sounds like a pseudocyst, it looks like a pseudocyst, it's walking like a pseudocyst, sometimes you may actually do an initial EUS just to do an FNA and sample and prove that it's a pseudocyst first with some of the fluid analysis up front before you come back and place the stent. Don't worry about, they'd be like, oh, you're draining all the fluid or anything. These things will reaccumulate if they're going to be symptomatic. Okay. So sometimes you want to be a little bit careful if you aren't getting that good history. Okay. So sometimes you'll see your endoscopist just do an FNA up front before they actually drain these. So, because this isn't all 100%. Everyone has a little bit of individuality on their pancreatic cysts. So. Cool.
Thank you so much.
This is great. Awesome. Thank you.